So the talk that I have is very small, brief. Throw some pictures in here and there to kind of lighten the mood a little bit. If you have a question, we'll save some time at the very end. If not, and you really need to ask me a question, just raise your hand. We'll pause and then I'll try and answer to the best of my abilities. Okay? All right. So we'll move to the next one. I'm just going to give you a very brief overview of what it is that I would do as a wound care physician. We're out of the hospital in the outpatient setting, and I take care of wounds from all the way from the head to the toes, and I'm not a surgeon, so I don't do surgery or I don't amputate, but we can do something what we call a debridement, which is really go down as deep as we can, comfortably to the patient's ability to bear pain. I don't use a lot of local anesthesia. I would if I need to, and so we'll kind of just play it by ear. So there are several different wound types. This list is not comprehensive. It's quite small, but broad categories. I'm going to touch on the two top ones, but just to list them out, we have diabetes, and notoriously known for the wounds that it causes. We'll spend a lot of time on that today. The other one is a venous ulcer wound. We tend to see this so very much in our area. In fact, if you compare a diabetic wound and a venous ulcer wound across the country, venous ulcer wounds are actually more than diabetic wounds, if you look at the numbers. The other ones are surgical wounds, and these are wounds that refuse to heal for whatever reason. And I get the patient in our office through our door, and we have several modalities of treatment that we can employ to help the wound heal. Traumatic wounds, not so commonly seen. Crush injuries, people working in Walmart or H-E-B, Kmart, and they operate these forklifts and stuff like that. And sometimes something slipped from the little prongs and it fell on a foot. We've had several of those come through the clinic and do real well, thank God, and heal out and go. Arterial wounds are wounds that look like venous wounds, but the underlying problem is arterial disease, and we're going to see a picture of that in a little bit. Where there's blockages, these wounds are the most painful of all the wounds that you can experience. If somebody has an arterial ulcer, just by the patient talking to you, you can tell this is an arterial wound. It just hurts like crazy. If you blow on it, it hurts. If you do this over it, it hurts. It's really bad. Pressure, wounds due to pressure, frequently on the back of the head, shoulder blades, depending on if a person is real thin, on the back of the foot, on the heels. And then wounds due to cancer. We see that, unfortunately, quite a bit as well. As you would think, these wounds don't do as good as we'd like them to, frequently, most of the time. If it's an isolated cancer that's more on the skin, we do real well, they heal and they actually go home happy. Some of the other ones, unfortunately, just with time don't do too well. Okay, so let's talk about diabetes a little bit. We're going to be spending more time on diabetes and venous ulcer wounds. So this one is a problem for us, like a major problem. Of all the patients that we have right now in the office, I would say about 35 to 40% are diabetic wounds. Now the numbers will actually throw you off if you're not very comfortable with the numbers. Look at that. So 1 in 4 Americans either will have or already do have diabetes. It's really, really common. This is from 2011. I'm quite sure the numbers are slightly on the higher side now. 26 million Americans. I'm not real concerned about the 26 million because they already know that they're diabetic. Okay? If you know you're diabetic, you're a little more cautious, you're a little more cognizant of the fact that, I need to look at my feet, I need to check my sugars and stuff like that. But look at that third point. 79 million don't know that they have diabetes. They're in the gray zone. Pretty much in the next 1 month, in the next 1 year, in the next 2 or maybe more, they are going to become diabetic. So, the doctor says, oh, you have something like pre-diabetes, or your sugars are slightly elevated. We've got to keep a close eye on it. So that number is really concerning. But last one, 27% of people who have diabetes, they don't know that they have it. Now, how do these guys find out? The 27%. So they're working out in the yard, or they're at home, they're taking their morning walks or their evening walks, and the shoe's a little tight. I actually had one patient walk in the office yesterday, newly diagnosed diabetic, 1 week. Okay? What actually happened was she had shoes that were slightly too tight. Now she walks like crazy. 15,000 steps a day. She actually has one of those things that you can put in your pocket, and it tells you how many steps you took. I was like, wow, I envy you. You walk so much. But what happened was, when she was walking, she didn't realize that if this is your foot on both sides, fifth toe outside, right? On the outside. The skin kind of got denuded and rubbed, friction, and before you knew it, when she took her shoes off at the end of the day, big wounds right here. 1 week from red, pink, black, both sides. And she came in yesterday because her family doctor said, oh, you know what? You need to go see the wound doctor. Okay? So, how did she know that she got diabetes? She got the wound, she went to see her family doctor, and they said, oh, your sugar's through the roof. So now she's a newly diagnosed diabetic. So those are the kind of people that will, individuals, patients that will fall in that last bucket. Really concerning. Also, as we age, we have a little more tendency to develop diabetes. So look at this. I'll just give you a second to read it, and then we'll talk a little bit about that. If I am a diabetic, which I am actually, I'm a diabetic. So let's say I have a heart attack. I have kidney problems. I have some eye problems. Let's say I have some problems with my arteries moving down. Now I go to the hospital, right? Get myself fixed, get myself checked, okay? But I have a wound. Now, if I take all of you in this room, and let's say we're all diabetics, just for imagination, okay? And if there's 20 of us, if we're diabetic, let's say 10 of us maybe have diabetic wounds, right? Those 10 patients will definitely go to the hospital. The other 10 have problems with eyesight. My kidneys are not doing so well. The doctor said we've got to watch it, keep an eye on it. Do I need to go to the hospital? No. So a diabetic that gets admitted to the hospital, more often than not, majority rules, would be due to a diabetic wound. And then again over there, you go into the hospital, you have a bad diabetic wound, you're seen by different people, different providers, and they'll say, you know what, I can't help you with this, we've got to cut it off. So 25% of those patients that went to the hospital come out with an amputation. Really sad. And there's billions and billions of dollars. This is just from 2010. Look at that number. Let me tell you something. Wound care is real expensive. It's just unfortunate that that's the nature of that part of the medical profession. Not to say that the other parts aren't expensive, they are. I mean, you know how it is. We have high insurance premiums and things like that. But when you have a wound, it costs a lot of money to get that fixed. Now, I deal with this every day, day in and day out. When it comes to diabetic wounds, for that matter, the cost even exponentially increases because the treatment options that are available are a lot more. Okay? And in every attempt that we're trying to do to prevent an amputation, we employ different treatment strategies, and unfortunately these things cost money. So the earlier a wound is caught, boom, you don't need to worry about all those things. There's different classifications. I'm not going to spend too much time talking about. I'll show you a picture of what the slightest to the worst type looks like, and then you can see what that means. So take a look at this little weighing scale over there. DFU stands for diabetic foot ulcer, DFU, okay? You take all the deaths, we're talking about deaths now, okay? People dying from breast cancer, prostate cancer, and Hodgkin's, which is a kind of cancer that's present in the lymph nodes. And all the people that died from those 3 cancers put together, and patients that unfortunately passed away from the complications of a diabetic foot wound, the numbers of just one smaller subset of the diabetic population, they die more than all those put together. Okay? For several reasons. There are so many reasons. As we become more poorly controlled diabetics, everything starts to shut down. So the healing also starts to take a back step. So it just makes things a lot more difficult, and it just shows that it's a difficult problem, something that needs to be caught real early. Okay, so it's not very clear, but on top you see what we call a Wagner grade. That's the type of classification we use, and you can see when you look at that wound on top, it looks decent, right? Pretty clean, not too bad. You don't see a bone, you don't see a muscle, you don't see a tendon. It might be infected, maybe not. It's hard to say just by looking at the picture. But I would say I want that if I have a diabetic wound, because that's grade 1. Treatable? Absolutely. Can it be healed? 100%. Okay? Can you prevent any complications? Absolutely. Okay? Look at the bottom right there. That looks nasty, right? Doesn't look too pleasant, doesn't look too nice. Now that's a 5. So we have a 1, and then you have a 5. 5 is the worst type that you can have. I have a picture of a 4, which actually doesn't look too bad, but it's still black. When we say black, it feels like this. Sorry. I didn't know it was mic'd, my bad. So it feels like this, like a stone, real hard. Okay, it's no longer soft like regular flesh and tissue. It's hard. You hold it, and you can take you can take a sharp blade, and you just slice it. It just lifts off the entire foot. But can you do that to the bottom? Not really, right? The whole foot. The only treatment for a wound like that at the bottom is an amputation. So if somebody walked in my door, say tomorrow in the morning, with a foot like that, and said, "Doc, I thought it was going to get better. It didn't," I'll say, "You know what? I'm so sorry, I can't help you. You need to go down to the emergency room, get admitted. Who's your family doctor? I'm going to call him right now, and tomorrow he's going to get an amputation, if not today." That's the only treatment for a wound like that. And then this is just post-amputation picture with some toes remaining. Okay, so these are some complications. I already touched a little bit about that. You can have, so diabetes is a global disease. I want you to look at it this way. It's global. It affects everything from the head down to the toes. It affects my heart, my blood vessels, my brain, my kidneys, my eyes, you name it. The nerves. There is not one organ system in our body that escapes the effect of diabetes, unfortunately. A well-controlled diabetic, however, none of this. You don't have to worry about it. Everything goes fine, and I'm walking down the street and a car comes and hit me, and I'll die from that, but not from the diabetes. Okay. Point being that there are some complications that are quite gravid in intensity, and so a stroke, and you see this frequently. Say fast or even face, and over here this is a fast. Very common complication in diabetes, people developing strokes because of the blood vessels getting kind of fragile, sometimes hypertension, things like that. That guy holding the chest over there is for a heart attack or problems with heart disease, and it varies in the spectrum, different things that you can see. And then again at the very bottom, I can't feel a thing, so I went and stubbed my toe, it got black. I went to the doctor's office, he said, "You got to cut it off." They tried to cut one toe, it didn't heal. They progressed to the other toes, and eventually they took all 5 off, and that's what you get. Amputations are really, really common in diabetes, and we want to avoid those as much as we can. For the most part, we actually do. Yes, ma'am?
Is it because diabetes is kind of hard or any wound to heal because it takes longer because we have diabetes?
If the diabetes is well controlled,
Okay.
then it doesn't take as long.
Okay.
Okay, that's one. The other thing is, because of the diabetes, there are several other problems, like problems with the circulation, problems with sensation, problems with healing, okay, due to infections and stuff like that. You know, bacteria like sweet, okay, and so they like a sweet environment. If it's wet, they like wet. So when a person walks in the office, the first thing we do, even before I step in the room, they check what is the status of the patient's circulation. Every single patient that has a wound below the knee, in fact even below the hip, we check circulation. If it's poor, I send him to the cardiologist ASAP. So those are reasons why the wounds don't heal. You know, it's not like when a patient has a heart attack, it's boom, I got to fix something, if not I'm going to have a heart attack again. With diabetes, it's so slow, it's so insidious that you don't realize it's working on the inside negatively. Okay? And so before you know it, you can't feel, I can't feel. I walk on a nail, I don't feel it. I take my shoes off and there's a lot of blood on my sock. I'm like, where did this blood come from? So I take a look at my feet and say, there's a nail over there. Dang, I didn't feel that. So then you go get your tetanus shot and your doctor says, man, that looks really bad. Okay, how's your sugar today? 326. I'm just using numbers. Okay, 214, 240. More often than not, when a wound is not doing too well, the sugars are not controlled. Okay, if the sugars are well controlled and it's pretty decent, you know, all the time, less than 200 at the maximum level, on a random, obviously, we can control things. Okay. Okay, so venous, we will go to venous ulcers, and this is also really, really common. We see this a lot down here in our community. Some of the risk factors that we see over there, I'm not going to list each one of them individually. Just look at them and then we'll move on from there. Also really difficult to heal. I'll tell you why. A venous ulcer wound is more an end result of who I am as an individual. Okay? Let's say I have heart failure. Okay? And because of my heart failure, I have a lot of fluid in my legs, I have a lot of swelling. You see that frequently, right? My legs are swollen all the time. Now, a treatment for a venous ulcer wound is, even if I don't do anything and all I do is firm compression over the leg, give it a little time, it's going to heal. Now here's a problem. I have heart failure, like I told you. I have swelling. My heart cannot pump too strongly. It's pumping at 30%. Normal, say 45, 50, 60%. So what I do, I go to the doctor and he says, oh, you know what? You have a wound on your leg. It's a venous ulcer wound. We're going to compress it. Okay. Oh, but wait a minute. You have heart failure. So I can't compress you. Why? Well, if he wraps my leg really firm and tight, what's going to happen to the fluid that was outside the blood vessels? It's going to go back into my blood vessels. All that fluid is going to travel up to my heart, right? In the circulation, in the circulation system. Now my heart is already weak. I can't pump too strongly, like I was saying. Now you have all that fluid that's coming to my heart. My heart says, wait a minute, what are you doing? Don't stress me out. So then I'm going to go into worse failure. So there are several complications that prevent us from really aggressively treating these wounds. There's problems with the circulation, blood coming down, blockages. If I put compression, it's going to make the blockage worse, for example. So that's why I say any patient that comes in the office with a wound below the hip, we check circulation, number one. If the circulation is good, we're golden. I'm so happy when I see those normal numbers. You say, you know what, I'm going to compress you, boom, go real aggressive, go real close on the local stuff that we do, and we're good to go. So these wounds will heal, but it's really long over time. Okay? Okay, we're going to talk about treatment options now. I'm not going to spend time on the other wounds like I mentioned earlier. Here's really something that, even though somebody asked me this the other day, oh, you even look at toes? I said I look at everything. Okay? The point being that when you go see a provider, a physician, whoever it is, okay, it's not me, it's not person X or Y or Z looking at, oh, there's a cut in my hand, put a band-aid, you've got to fix it. It doesn't work that way. I have to look at you from your head to your toe. Make sure you have good nutrition. Make sure your circulation is good. We're going to talk about those things. Okay? Make sure there's no infection. If you have a wound that's wet all the time, I've got to ensure that I'm drying it out appropriately. It's never going to heal if it's wet all the time. So there are several things. Treat the whole person, not the whole. You see, I thought it would be funny. It's not really funny, but whatever. Okay, so here, let's talk about this. So we're going to talk about general stuff that we do as physicians, and then stuff that I can do locally to kind of help the wound heal as fast as I can. So before I go to this step, nationally we have wound care offices or clinics all across the country, right? I mean, if you go to Florida, if you go to DC, if you go wherever, what have you, if you look in the directory, you can find a wound care clinic at most places, okay? Some it's a little more difficult to find, but you can find. Now, if you take all the clinics, okay, there are like Medicare. Medicare doesn't track the healing rates as much, but there's an organization that kind of does it. And you can actually see, hey, you know what? Clinic X in Harlingen, Texas, how did they do? Let me check. Okay? So there's a national average for healing, and this window of time is 14 weeks. 1-4. So if you walked in my door tomorrow, my goal would be to have you heal your wound with all the strategies that I can employ in as fast as 14 weeks. That seems like a lot. It's more than 3 months. Okay? I have patients that I treat for 2 years and they still have a wound. Okay? And there are several reasons why those wounds refuse to heal, but we still see them. But when you talk about averages and healing numbers, 14 weeks is my window as a physician, and people track me against that. Okay, so we do relatively well. We're above the healing national average. Okay, so nutrition. Okay, every person that has a wound, when I say every, I would say more than 95% of individuals that have a wound, when I talk about a wound, I'm not just saying a cut, but something a little more serious, has a slight nutritional deficiency, almost all the time. Okay? Poor protein levels. Protein is, of all the food groups that you know, the one group that's the most essential and critical to wound healing is protein. So when a patient walks in that door tomorrow, he's a new patient to me, I check some things. If he's a diabetic, I check an A1C. You know what an A1C is. I check something which is called a prealbumin, which is the most accurate reflection of what my nutritional status is yesterday, the day before yesterday, and today. Okay, it's called a prealbumin, and we have normal number. Frequently it's lower than the normal, or it's just touching right about there. Okay, how's the blood? How's the circulation? We talked about that. We're going to spend some time on that, just a few minutes. Is there infection? Not just in the wound, but is this person coming in with a 104, a 103? Somebody came in the office today, one of my colleagues' patients who had to step to the OR around 12:15, and fevers over the weekend, and he said, would you please take a look at the wound and tell me if he needs to go get admitted to the hospital. So he has a wound on his heel right here, on his foot, right about where this black line is, about that long, about that deep. Okay, it was created, the wound, because there was an abscess and pus that needed to be drained. So I step into the room. He has no fever today, but he had fever over the weekend, a lot of fever, fevers, chills, okay, So I take a look at the wound, put my gloves on, and I touch him right here. Hot. Really hot. I say, you know what? I don't even need to look below that because this is an infection. He needs to go to the hospital. You know, a simple back trim, a simple doxycycline at that point won't do the job really. He needs, boom, hard treatment, right? So I said, sir, you need to go to the hospital. Go down to the ER and you'll get admitted. Is there infection? Now we come down to the local wound where the wound actually present and say, is it too dry? Okay, there was this really cool guy in 1962. I wasn't even born then. His name was Dr. Winter. So they call it the Winter of 62. It's easy to remember. So this doctor did some studies and said, you know what? Let's take a guinea pig and create multiple wounds, okay, in the lab. And so they made several wounds, and they kept some wounds super dry, some wounds middle of the road, and the other ones to kept them moist, okay? Not wet, not sopping wet, but moist. And he tracked the wounds over time, nothing else. He just watched it. And the wounds that were moist did the best, okay? So now we say that the wound needs a healthy balance, a healthy middle, which is sometimes hard to achieve or hard to find, but you know, with time we're able to get that real close. So is it too wet? Is it too dry? If it's too dry, I need to make it wet. I need to put something on that wound bed that will make it moist. If it's too dry, like I said, if it's too wet, wick it away. Make it dry. Okay, not bone dry. Locally, if there's infection, every time we have a wound, I take a piece of tissue and send it to the lab. I get a number back, I get a result back. 2 days, 3 days pushing it, sometimes 5 days. I can tell within the first week of when the patient comes in, is there an infection, yay or nay? If there's an infection, we treat it, okay? Then debridement is simply nothing but cleaning the wound. We have several instruments that we use, different types like they use in the OR, but we don't go as deep down because it's not general anesthesia. You know, it hurts. I recently had a wound on my finger right here, and I got to live the life of a wound care patient. Trust me, it's not fun. So I can totally relate to an individual that has a wound. You know, it's really cool. It's really easy, not cool. A person walks in my door, I say, you know what? Don't get it wet. So this patient in his mind is saying, seriously? How am I going to shower? How am I going to do this? I sweat all the time. Don't get it wet. Okay, fine. Keep it up and elevate it all the time. I got to walk, I got to work, I got to go from my bedroom to my bathroom, or you know, what have you. So when I was treating this wound, and actually got some help, I had to get the hand surgeon to actually cut it. Painful, let me tell you. I was telling all my staff in the office, yeah, I know what it feels like now. You know, you got to walk in those shoes sometimes. So yeah, but we can do a lot of cleaning topically, locally on the wound to the point where it bleeds, because we want bleeding, we want a healthy bleeding base, and it doesn't hurt for the most part. Then the other thing is hyperbaric oxygen therapy. We're going to talk a little bit about that as well, because diabetic wounds after a certain class by default meet criteria for treatment. In fact, if you do the right thing, and you know, we have certain things that we use to take the pressure off the wounds, as most often they're on the feet. It's like a cast. When you have a fracture, they put a cast. You know, the orthopedic doctor will put a cast. And this is a similar cast, and it takes all the pressure off that wound. They say that only if you use that modality of treatment, 6 weeks to 8 weeks, 70%, they'll heal. What did I do? All we did was take pressure off that wound. It's amazing what that can do. So HBO is really cool if a person is not claustrophobic, because half the time they'll say, oh, I can't do this. Okay, it's about this big, and you'll see a picture, really clear. It's not glass. It's really thick acrylic, like a thick composite plastic, about 2.5 inches, and it's clear. There's a bed that slides in, and the door is behind my head, so I can't see it. Everything else that I see is transparent, so I can see everything. And we give them a TV to kind of keep them occupied. You have a choice of movies, we'll try and provide that, things like that, because the treatment is an hour and a half of actual treatment time, 90 minutes. But by the time the patient comes to the office, gets undressed, because we don't let you walk in with your clothes and say, okay, go and have your treatment. We give them a cotton gown, no colognes, no lotions, no earrings, when I say earrings, no jewelry, no watches, because it's pure oxygen. And when you see the trucks that go on the road that says pure oxygen, on the behind there's that hazmat sign that says what?
No smoking.
No smoking? Because it's flammable, right? Exactly. So pure oxygen, 100%, is flammable. It's actually labeled as actually a drug. Oxygen is labeled a drug. But do they do well? Oh, trust me, they do. I'll tell you why they do real well. And then at the bottom, skin substitutes. If you go to a surgeon and you have a wound, he's going to say, I'm going to do a skin graft. So boom, he's going to take it from my butt, from my thigh, somewhere, right? You're like, does he have to do that? Well, here's the difference between the surgeon and me is I can't, because I'm not a surgeon. So we have skin that's made in the lab, okay? And comes in different sizes for the most part. And on diabetic wounds due to venous disease, and now with Medicare kind of expanding the role of wound care, if I can put it that way, I can use certain skin grafts from the head to the toe, even though I'm not a surgeon. Okay? So that's really cool. I'm really happy that we can do that. And sometimes all it takes is one skin graft. Boom, they're healed. Sometimes it takes 3, 4, depending on how we're able to control things. Okay, so we'll talk about food a little bit. I want that, not this. Okay? Now, more often than not, we'll gravitate kind of towards this, right? Look at that. The other day, when I was creating this presentation, I said, man, that looks so good. Okay? So here's something that I'm going to ask you. It's a challenge, okay? If you do fast food, that's okay. Keep it to once a week. That's it. No more than once a week. Go to town, have your burger, get it fully loaded. Okay? I'll just let you know though, the biggest enemy of a diabetic is fries. Not good. When I found out, I stopped the fries, let me tell you. Completely, zero.
Is diabetes ever reversible?
Oh yeah, absolutely. It is. Yeah. If it's not reversible, most individuals will say, it's not reversible, but you can control it. Here's how I would say it. Okay? I'm a newly diagnosed diabetic. My A1C is 7.2. Normal A1C is 5.8 to like a 6.2. Okay, that means my blood sugar is less than 125 on a fasting. Okay? Now, remember I talked about the 79 million people that are pre-diabetic, 105 to 124. So that A1C, when you do a 3-month measurement, kind of adds up to between 6.0 to a 6.3. So if your A1C today, if I check it, is a 5.5, and 5 months ago it was a 6.5, I'd say you've done really well. Okay? If you're on 3 medications or you're on 2 medications, I'll say let's back off all the medications if we can. Maintain a healthy lifestyle, maintain a good dietary balance, exercise regularly. Come back in 2 months, I'll check an A1C. Okay? So you come back in 2 months, we check an A1C, and it's 5.5, 5.6. I say, great. Let's look at it again in 6 months. But if we went from a 5.5 to a 6.2, we know that the medications were keeping you at bay. Right? So I'm going to say we probably need to add something back in. But can diabetes be reversed? There's a lot of professionals that will tell you, yes. The main treatment before medications are started is lifestyle modification, really, when you think about it. Exercise, lose weight, eat healthy. You're good. But it's a discussion in progress. It's not a one-step, hey, the doctor said I can stop all my meds. It doesn't work like that. Okay, so we're talking about blood. Is the circulation good? Right here on your left side is normal, okay? And then middle is where you see that yellow stuff, is where that's plaque or due to atherosclerosis, cholesterol, what have you. And again, the same thing on the right. Look at that lumen over there. So the yellow on the sides is the plaque, and then look at that little thing. It's so thin. What was like this is now like this. But your lifestyle is the same. You still walk all the time. And so when patients have problems with the circulation, they're going to tell you. They'll come to you and they'll say, what's your name, ma'am? Esmeralda. Your friend is going to come to you and say, 6 months ago I could walk from my house to the HEB, no problems. And then since last week, I can't even walk half a block. My legs hurt like crazy and it cramps. So I have to stop and I have to sit. I feel better, I walk a little more, but the pain comes right back. Because when you walk, there's not enough circulation going down. The other thing that they'll tell you is, they're in bed, they're sleeping at night, oh, my butt hurts like crazy. Or the back of my thighs hurt like crazy. So what they're going to do is they're lying down flat in bed. They're going to get up, get to the side of the bed, and they're going to do this. Exact position. You know why? This takes the pressure off and the blood moves down. It feels a lot better, they can go back to sleep. After some time they'll say, you know what, this works better, let me just sleep in my recliner. It's true. We kind of adapt to what our body is telling us. And this is, you laugh, but it's so true. I have patients that have been sleeping in recliner for years. Simply because it hurts. Why don't you talk to your doctor? Why don't you do something about it? Well, I'm here now. I'll say, well, I'm going to help you as much as I can. I'll move heaven and hell for you. And I actually do. So anyways. Okay. Infection. Okay, bugs. Oh man, it says the right drug for the right bug. Those days are gone, my friends. Those days are gone. A lot of the time, it's here. We're on this side already. The bug is going to say, it's not going to work on me. How much do I see this? Oh my goodness, a lot. I would say about 40 to 50% of the time, the infection says it's resistant to this this antibiotic, that antibiotic, and then there's different kinds. You name it. Some are more serious, and some are like, I can still treat this, no problems. Everything we can treat, thank God for that nowadays. Okay, but does it make life more difficult and more hard? Absolutely, it does. Okay, yeah, don't patch me up like that if I saw you. Look at that top one, Look, doc, I did a great job. I'm like, how about not? Okay? Just to show that, we have a lot of pretty cool stuff that we can use on the wound, which is appropriate to that context, to that setting. And does it work? Oh boy, does it work. It sure does. Okay? It works like, I can't really stretch myself and say that. So look at that. That's pretty cool. This is HBO, okay? So this is way back in, it's in Ohio. And let me read, okay? It says, resembling a strange machine from another planet, a huge steel ball standing 5 stories high is being erected at Cleveland, Ohio, so that persons suffering from diabetes may be given treatment under ideal conditions. In the strange spherical health hotel, patients will live constantly, so they're going to live there all the time. It's not like you go in and go back home. You live there, where am I? Live constantly in an atmosphere of high oxygen content, maintained at a pressure of 30 pounds per square inch. Okay? Twice that of normal atmosphere, twice that of this. Okay, there are 5 floors, there's an elevator that takes you up and down, and then you see those little round holes. It's like the port in a submarine. It's like port windows, so that it resists the pressure of the oxygen. And then we have treatment tanks for pressure, and there's a cooling tank as well, because pure oxygen under pressure is hot. It gets hot. It expands. So from there to here, this is what we have today. Pretty cool. The one on your extreme left top is what I have in the hospital right now. We have 3 of those over here, and they're called monoplace for single place per person. So single person chambers, and that little blue thing that you see on here is the only opaque portion. That's the door that opens and closes. It's like this, and I'm sliding in this way, and I have a TV. There's a telephone on the outside for the technician to talk to you so that your privacy is maintained. Okay, you don't need a telephone on the inside because it's mic'd, everything is mic'd. Okay, once you go inside, they close the door, snap it shut, and then they have knobs on the outside that they slowly go with time and increase the pressure to 33 feet of pressure. So this is right now 1 atmosphere. We're at 1. Okay, we're breathing normal air, 21% oxygen. I go into this treatment chamber, which is called an HBO chamber, closes the door, turns the knob, all the air is gone, there's pure oxygen, 100%. No nitrogen, no other gases, no more 21%, 100%. And as the knob is turned, it makes pressure. So when you go in an airplane, you feel the thing in your ears, right? Or in the pool when you go deep down, you feel that pressure. It's something similar. So the person that's helping you with the treatment will say to you, swallow. When you swallow, those tubes that connect the ears to the back of the mouth, it pulls on the eardrum and it equalizes the pressure. It's the same thing like doing this when you're in the plane, in an airplane, okay? I have instances when individuals say, I tried the swallow, I tried to drink a little water, nothing is working. I say, you know what? I think the treatment is really important. I'm going to send him to the ENT specialist. And like when we're kids, the babies, when they get fluid in the ears, what does the ENT specialist do? He puts those little white things, the white tubes. Yeah. I do this. Well, I don't do it. The ENT specialist will do the same thing. And more often than not, we can just put one, and that takes care of it. Yeah. And they fall out by themselves. 3 to 6 months, it's out.
What happens if you want to use a potty?
Well, we ask you, that's a very valid question. So before you go into the treatment room, we'll say, do you need to use a potty? Do you need to empty your bladder? Please go. Because once you go inside, then we close the door. It takes about 7 to 10 minutes to get you to that pressure, 33 feet of sea level that we're talking about. Okay? And then on the other side, same time. I can't go boom, boom. Oh no.
So you wear a diaper?
Pardon me?
You wear a diaper?
Maybe.
Some do. Most of the time, they can hold. I have, the oldest person that has been in our treatment chamber was about 86 years old. An elderly lady, did real well. No problems. Do I have problems with that? Yes. We have to stop the treatment. We tell them to wait 5 minutes, 7 minutes, and we try to get them back to room pressure as soon as we can so they can go to the restroom. But the restroom is right there, it's close by, it's accessible. We have wheelchairs. I have 2 staff constantly on site to man these chambers all the time. So that is an issue that we frequently do. Even if you have the runs, hello, I have the runs, I gotta go. So it's something that we deal with all the time. Yeah. That over there and in the middle, that's called a multi-place. There's 10 people can go in at one time. Okay, the closest place where they have this, and this is good for people that have claustrophobia. San Antonio is the closest one. Brooks Army Center over there, since they have a lot of, the people that fly and even dive deep sea with training and stuff like that, they can go get treated over there with the bends, like they call it. I'm almost done. Okay, so this is a brief indication list of what can be treated with HBO. Diabetic wounds with an abscess or bone infection. Okay? Chronic bone infection that was treated for about 4 weeks, IV antibiotic therapy by mouth, it didn't heal. I could repeat the MRI or a bone scan and says, there's still bone infection. I can treat it. A skin graft, a flap surgery that didn't do too well, starting to look a little dusky on the edges, yes. So I had breast cancer, or I had head and neck cancer, and I got my chemotherapy, I got radiation, and then 6 months down the road, I start to get some pain in my jaw, for example. Or I got a wound on my breast that won't heal, and then they come see me, or they go see their oncologist, their cancer doctor, and he says, I think we need to look at this a little more closely, get an MRI, which says that there's chronic results of the radiation. It causes, you can't see it on the outside, but when it's in the bone, it causes scarring, and it doesn't take much to fracture that bone. Okay, I had like a 80-plus-year-old gentleman from Ohio that was window Texan, came down, and his ENT specialist said, hey, they have a treatment chamber down there in Harlingen. Go meet those guys and get some treatment. Okay, so I called the guy up and we kind of discussed on a plan of treatment. 5 treatments. He had problems with his jaw. He had a little metal brace that kind of went like that. Obviously, it's inside, you can't see it. If you take an X-ray, you can. And 5 treatments later, he comes back and says, it was not even his follow-up appointment. He says, Doc, it's tighter. It works. I mean, and then I did 20 for him, and his ENT specialist from Ohio said, we're good. You're golden, you can stop. Gas gangrene. In diabetic wounds, we see this somewhat. Severe infections, really, really difficult to treat. You can spell Mississippi, and it's already traveled beyond Mississippi. Point being that the infection is so fast, if you don't step in now, you can't say, I'll see you back at 12 tomorrow afternoon. He has to go to the operating room right now. We're almost done. Okay, so these are some pictures from our patients in the office, before and afters. That on top is it's actually a diabetic wound. It's a 3. Okay, how do I know it's a 3? An MRI was done, which showed that there was fluid and abscess collection in the muscles, and no bone infection. So that's a 3, and then that's an after. This is about 2.5 to 3 months post. I don't have the dates over here. This is a venous ulcer wound. It's right here on the leg, right this spot. 1.5 months later, it's not very clear, I'm sorry, but you can see that she did real well and it healed. This is a diabetic wound. It's a 4. If the picture was clearer, you can see it's actually black in the center, and you see the date over there. Oh, my bad. Wait a minute. 9/29. Again, sorry. This is a venous ulcer wound. This is a venous wound. 6/30, 8/5, 9/29, healed, discharged. The last one is the other wound. So that is black. You can see even by looking at it, it's black. Now this wound is present right here. On the outside, near the 5th toe, on the outside right there. Okay? The picture doesn't do too much justice because it's taken from different angles. And it was black, hard as a rock. Hard as a rock. The first thing that we do with those things is we need to get it soft so we can take it off so that it can heal. It doesn't heal from the bottom up most of the time. It heals from the sides. So you need good, healthy sides for the wound to kind of crawl in or creep in. So you see, this one took a long time. 219 was when he first came, saw me. 430, that's not a skin graft, but it's like a wannabe skin graft, which works really good. It deposits protein in the wound. Okay, 430. And 730, there was a bone, this is a bone infection also. So it kind of like fits one classification, it also fits the other. Okay, because it's black, it's a 4 by default. Because it's a part of the foot. If the entire foot, I'm going to say I can't help you, I'm so sorry. But this, oh yeah, absolutely. So it's a 4, but it's also complicated by a bone infection. So he has to get IV antibiotics. He did get incomplete HPO because he said, I'm done. I can't do this anymore. So he got 38 out of 40 healed.
Doctor,
Yes, ma'am.
we talk about infection. questions on that outside. I have both toes ulcers, and they were afraid I was going to lose my toe. But I went to the wound center in Brownsville with Dr. Ayala.
Yeah.
Anyway, is there such thing as an infection inside the toe?
Yes.
What caused the infection? Of what?
Well, it went from the outside.
Pardon?
It went from the outside, from the wound.
Yeah, but you don't see it.
Well, that's how we take a culture. When you have a wound, I can't tell,
Right.
for the most part, if it's infected or not. But if you come with me and I see the toe, I can smell it,
Yeah.
I see the drainage, I look at it and say, you know what, this wound is infected. I'm trained to do that. So I can tell right away. It helps me to confirm it when I take a piece of tissue and say what kind of bacteria is growing in that wound. So I can treat you appropriately.
You know what? I noticed that because both toes, I never been told or have done like what you call like a culture.
Yeah.
They have not done it, but this one, they heal. This one is because I have a drop foot. I have polio.
Yeah, yeah.
So that's the reason I have the ulcer, and it has
Yeah.
not healed yet. But they have never done that culture or biopsy or whatever. They're different, that's the reason, right?
I guess.
Okay. Thank you.
No problem. Some things that you should do. It says over there, do not smoke, but I would say avoid nicotine in any form. Okay, it's one of the nastiest things. See, so when I have a family history, a strong family history of heart disease, boom, I'm going to get a heart attack. If I smoke, that chance then just went up, boom, 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 right through, all the way up there. Okay, what nicotine does is it doesn't affect the large arteries. It affects the small ones. Okay, so small vessel disease in the heart, not good. Okay, or in the extremities, because they're already small to start off. Do not walk barefoot. If you have to buy shoes, buy them in the afternoon so your feet have some time to kind of expand. You know, no, really, it's true. And don't go curvy on your nails when you go to the salon. Okay, and then see your physician at least once a year if you're diabetic. They'll check your sensation and check several other things, and then talk to your doctor if you have a wound or a blister. That was cool, not too bad.